So in dealing with pediatric patient, usually makes us feel that we are taking care of two patients, the patient in itself as well as their parents and guardians. It is worthwhile to know that children usually behave in a way consistent with how they truly feel. Thus, they should be handled gently, and establishing rapport would be of great help in dealing with them. In pediatric history, the source of information usually includes the patient, as in the case of older child, the parents or caregiver. However, most of the time, information almost completely depends upon caregivers, and noting their reliability is equally important. Key elements in history taking include establishing an appropriate atmosphere and asking questions in a non confrontational manner. So the first part of comprehensive history taking includes identifying data or the general data, which includes the name, the age, the sex, nationality, religion, address, and other relevant data applicable. So the chief complaint, it is the main reason causing the patient to seek care or brought for consult or admission. So the most common chief complaint for pediatric patient includes fever, cough, LBM, vomiting, abdominal pain, rashes, and seizures. So the history of present illness amplifies the chief complaint. Details of the present illness are recorded in chronological order. For instance, for the sick child, it is helpful to begin with the phrase, the child was apparently well until the number of days before the visit. This is followed by the daily documentation of events leading up to the present time, including the number of days before the visit. For complaint of pain, it must contain essential information like the location, the quality, the quantity or severity, the timing including the onset, duration, frequency, setting in which it occurs, the aggravating and relieving factors, and associated manifestation. It must also contain remedies given to relieve the symptoms, if any. If medications were given, we should note the type, the dose, the frequency, and the response. History must build up until the reason for confinement. For neonates, however, the history of present illness should start from the prenatal or perinatal period, maternal and birth history prior to describing the present condition. So next is the review of system. This addresses the information about each system that were not touched in the present illness. This showed this is showed systematically to avoid omissions. Questions concerning each system may be introduced with a question such as, are there any symptoms related to each systems um, as shown in the table. So for the maternal or prenatal history, questions to be answered include those regarding the health of the mother during the pregnancy, the number of previous pregnancies and their outcome, the radiograph or medications taken during pregnancy, and if the mother's weight gain has been excessive or insufficient, this also should be noted. And for the birth history, information regarding the duration of the pregnancy, the type of delivery, whether it is spontaneous, forceps assisted, or cesarean section, the person who attended the delivery, the birth weight, and the presence or absence of complications. Many informants are aware of the Apgar scores at birth and any unusual appearance of the child, such as presence of cyanosis or respiratory distress, and any resuscitative efforts that took place and their duration. The time of onset of any abnormal stage should be noted. Also, in this area of history taking, information regarding the newborn screening result should also be sought. So for the nutritional or feeding history, for instance, for infants, we should note whether the baby was breastfed, bottle fed, and if the infant has been bottle fed, inquire about the type of formula used, the amount taken during a 24-hour period, and we should determine the age at which solid foods were introduced and supplementation such as vitamins. And we should also identify the age at which the weaning occurred and the method used for weaning. While for older children, assess the feeding difficulties, the amount of food usually consumed, and decrease or absence of appetite should also be noted. And whenever possible, make an appraisal of the past growth and development. Estimation of the physical growth rate is important. Attempt to ascertain the birth weight, subsequent weights, and length desirable. Any sudden gain or loss in physical growth should be noted, particularly because its onset may correspond to the onset of an organic or psychosocial illness. It may be helpful to compare the child's growth with the rate of the growth of his or her siblings. So, according to the Philippine Society of Developmental Pediatrics, it recommends developmental surveillance should be done at every child visit or at specified ages such as 9 months, 18 months, and 30 months, and yearly thereafter. Developmental surveillance, it is a process by which the healthcare professional recognizes the children who are at risk of developmental and behavioral conditions, ages at which major developmental milestones were met, aid in indicating a deviation from normal, such as the age of dressing oneself, tying one's shoes, hopping, skipping, riding a tricycle and bicycle should be noted, as well as the grade in school and school performance. So immunization history includes the type of immunizations received with the number, the dates, the sites given. The reaction should also be recorded as part of the history. And we should determine missed opportunity or the need for booster immunization. However, topics about immunization will be further explained in succeeding lectures. So the past medical history includes data about the previous illness, the accidents or injuries, surgical procedure, previous hospitalization, and presence of allergies. While your family history provides evidence for considering familial diseases. Use of genogram could also be useful. Outline or diagram of the age, health, or age and cause of death of each immediate relative, including grandparents, parents, or siblings. We should also note the presence or absence of conditions in the family, both infectious or contagious illnesses. So other relevant data pertaining to the patient's living condition, such as hobbies, lifestyle, activities of daily living, influences of the community or the school, peer group, as well as family socioeconomic circumstances should also be noted, as this may affect the child's belief and attitude as well as health-seeking behavior. So unique to adolescent, starting at the age of 10, is what we call the HEADS assessment, which stands for the following parameters. For the home, we should inquire about all individuals living with adolescents and their relationship with these individuals. For education, we need to note the name of the school, the year level, whether they have recently changed school, their favorite or least favorite subject, their relationship with their teachers or classmates, experience with bullying for adolescents who are working, what inquire about the nature of past experiences with their employers and their relationship. For the activities, we should inquire about hobbies, recreational activities, sports and exercise, activities they do with their friends, hours they spend on TV or computer or cell phone. For the drugs, before inquiring about the patient in itself, inquire first whether their friends drink alcohol, smoke, or have tried illicit before inquiring to the adolescent. For sexuality, dating history or relationship with same or opposite sex, presence of sexual activity, contraceptives use, and for females, inquire about LMP or last menstrual period and problem with menses. For societality, presence note for history of depression, suicidal ideation, and history of attempts to hurt self. And for safety, we should inquire if they feel safe at home, in their neighborhood, or presence of guns at home, previous or current experiences of abuse. So after taking the history, now we will proceed with the physical examination. So there are a lot of things to consider in taking the physical examination of a pediatric patient. So you may need to alter the order of examination for patient compliance or for uncooperative or hyperactive patients. Do not force a child to do something that may be frightening or uncomfortable to them. So examination of an infant or child begins with observing him or her and establishing rapport. The order of examination should fit the child and circumstances. The approach is gentle but expeditious and complete. Some children are best held by parents during an examination, while others, the rest, parts of the examination may require restraint by the parent or assistant. Only the part that is being examined need to be uncovered and then it can be reclothed. Except during infancy, modesty should be respected and the child should be kept as comfortable as possible. And it is wise to make no sudden movements and complete first those parts of the examination that requires child's cooperation. Painful or disagreeable procedure should be deferred to the end of the examination, and this should be explained to the child before proceeding. For the older child and adolescent, examination can begin with the head and and conclude with the extremities. When the complaint includes a report of pain in a certain area, this should be examined last. So for the general survey, a statement should be recorded about the alertness, presence of distress, general development, nutrition of the child, the mental status, activity, unusual positions or apprehensions, cooperativeness, and which may direct one to consider an acute or chronic illness or no illness at all. So vital signs for the vital sign includes the respiratory rate, which determined by counting while observing the movement of the chest for complete 1 minute. So based on the WHO, the following value serves as a cutoff for tachypnea at this respective age. These values are commonly used in the clinical setting. In measuring the blood pressure, the right arm is usually recommended for standardization since there is possibility of false low reading in the left arm, as in the case of coarctation of the aorta. We need to use the right cup size, in which the bladder length it should be more than 80% of the upper arm, while the bladder width should be greater than 40% of the upper arm circumference. And routine measurement of BP among children should start at 3 years old. However, those at 3 should be start at an earlier age. So hypertension is defined as having an average of systolic BP and diastolic BP more than the 95th percentile per age group on 3 or more occasions. While for pulse rate, it can be obtained at any peripheral pulse. However, radial and brachial pulse is usually preferred. So the following are the normal values, which are age specific. So another important parameters that matters in pediatric patient are anthropometric measurement. So anthropometric measurement includes the weight, head circumference, height, length, and BMI. Weight, for instance, is very important since it is used in IV fluid rate and drug computation. Decrease in weight percentile may be due to decreased intake, malabsorption, or increased metabolic rate. However, child's length is measured until 2 years old, and after which height is measured. Decrease in height may be familiar or may be seen in conditions affecting weight or independent of weight. Increase in height may be familiar or associated with certain genetic and endocrine abnormalities as well. And the head circumference is routinely measured until 3 years old. Microcephaly can be due to congenital infection such as your cytomegalovirus virus, and macrocephaly may represent a pathologic state such as your hydrocephalus. So in pediatric physical examination, start with the system that is mostly affected. Examination should be systematic. It includes inspection, palpation, percussion, auscultation. Although the remain recording of the physical examination should be from head to toe. So examination of the skin, note for the color, the moisture, the temperature, the texture, mobility, and the turgor. Characterize the lesion according to the location, distribution, patterns, shape, type, and color. For the head, in an infant, the size of the topography of the anterior fontanelle should be noted. The anterior fontanelle is the largest one, measuring 4 to 6 centimeter and closest between 12 to 18 months. And the posterior fontanelle measures 1 to 2 cm and closes by 6 to 8 weeks. Bulging of the fontanelle may indicate increased ICP, while depression of the fontanelle is found in decreased ICP and may be a sign of dehydration. In assessing the head symmetry, should be examined from various perspectives. For instance, plagiocephaly, as described in this picture, is characterized by flattening of the occipital skull, while your craniocytosis refers to the premature fusion of one or more of the sutures of the cranial bones and should be considered in any neonate with an asymmetric cranium. And abnormalities in the hair may be associated with systemic disease or abnormality, for instance, dry, coarse, and brittle hair may be associated with congenital hypothyroidism. Next is examination of the eyes. The shape and position of the eye should be noted. Any abnormal eye movement and the ability to focus on the examiner are important to note. For the ears, the size and any aberration in shape of the external ear should be noted. For instance, a low position below the level of the eyes may indicate a condition such as Down syndrome. The otoscopic exam is performed by gently pulling the auricle upward and backward. In children, the auricle should be pulled downward and backward. This process will move the acoustic meatus in line with the canal. So for the inspection of the auricle and particularly tissues can be done by checking the 4Ds: the discharge, the discoloration, the deformity, and the displacement. So the normal eardrum is pinkish in color, translucent, and in neutral position. Any discharge from the ear canal can be a result of otitis externa or chronic untreated otitis media. If the discharge is accompanied with perforation of the tympanic membrane, otitis media is highly considered. Discoloration in the form of ecchymosis over the mastoid area is called a battle sign, and this is associated with trauma and should be considered as an emergency. And examination of the nose should note for the symmetry, position of the nasal septum, and the presence of discharge. So for the examination of the mouth and We should assess for symmetry, such as drooping of the corner of the mouth. The lips and the mucous membrane should be examined for evidence of cyanosis. The color of the oropharynx should be noted. The size of the tonsil and the tonsillar pillars, and any discharge should be noted. Presence of strawberry or raspberry tongue is seen in specific stages of scarlet fever, as well as in case of Kawasaki disease. Examine also the oral mucosa, those having creamy white reticular flakes commonly seen with thrush. It is caused by Candida albicans. We should also examine the teeth for dental caries, color of the teeth, the number of teeth and for dental occlusion. And in examining the neck, we should note for the masses, enlarged glands, carotid roots, mobility, and presence of webbed neck. So, for examination of the breast, we should examine for symmetry, palpate presence of mass, presence of lesions, discharges, and for adolescent, we should note for the Tanner stage. So, for the examination of the chest and lungs, note the symmetry of the chest. A symmetric expansion may be seen with pneumothorax or diaphragmatic paralysis. Also, note for the presence of abnormal shape, such as your pectus excavatum or pectus carinatum. So, we should inspect the thorax for the color, respiration, type of breathing, presence of retraction. And we need to auscultate the breath sounds, the rate, the ease, the depth, and the rhythm. And we should palpate the thorax for presence of tenderness or respiratory excursion, presence of vocal or tactile premitus, and areas of abnormality. So for the breath sounds, stridor, it is a continuous inspiratory sound that denotes upper airway obstruction. While your wheeze, it is a continuous expiratory sound, usually high pitch and denotes lower airway obstruction. Crackles, coarse crackles, it is a low pitch, inspiratory, long continuous sound which denotes lung tissue disease. While your fine crackles, it is high pitch, inspiratory, short, discontinuous sounds, usually also denotes lung tissue disease. While your rhonchi could be either inspiratory or expiratory, which is continuous low pitch and denotes lower airway obstruction or lung tissue disease. So for examination of the heart, a history of excessive perspiration and difficulties in feeding are two of the most common complaints of early congestive heart failure. Important questions to ask the parent: has the infant been feeding? Does he or she has difficulty in breath or upper exhausted? Does the child tire easily with eating or playing? Does the child perspire excessively, or especially with the efforts such as feeding? So we need to inspect for presence of precordial bulging, lesions in the chest, palpate for presence of heaves, thrills, presence of murmurs, and the location of the apical impulse. So from birth to 3 years old, the point of maximal impulse or the apex beat at fourth intercostal space left mid-clavicular line and usually moves into the fifth ICS left mid-clavicular line as the child grows. So for the examination of the abdomen, examination start with inspection, followed by auscultation, percussion, and palpation. However, the recording of the result still follow the IPPA format. Inspection is the most important first step. The order of examination has been changed slightly in that palpation is done last. So it is a good idea before performing examination to ask the child if they need to use a restroom. For the examination of the infant or toddler, the knees may be bent in order to relax the abdomen and the child's arm down at their sides. So we need to inspect presence of rashes, scars, lesions, or discoloration. We need to observe for the overall contour and symmetry. Inspect the umbilicus for the shape, signs of inflammation, or presence of hernia. Next is auscultation. Auscultation of the abdomen should be done before palpation or percussion, since the latter may alter the frequency or quality of the bowel sounds. Listen to the four quadrants, noting the frequency and quality of the breath sounds. I mean bowel sounds. Abnormal sounds, such as gurgles, clicks, growls, and the frequency of sounds is from 5 to 34 times per minute. An increase in frequency or pitch of bowel sound may be associated with diarrhea, while decrease or absent may be associated with ileus or peritonitis. Percussion in of the abdomen is same as an adult patient. Because children tend to swallow a lot of air when eating or crying, the stomach and intestine has a greater amount of air in them. A distended abdomen may signify an obstruction, infection, presence of ascites, or an abdominal mass. Palpation will reveal masses. We should note the size and the location, presence of hepatomegaly, or any sources of pain. So the normal liver edge is up to 3.5 centimeter below the right costal margin in newborn and up to 2 centimeter in children. For the examination of the extremity, it should be examined for for the symmetry and note for presence of clubbing, cyanosis, and edema. We should also note for any deformities such as club foot, uh, the range of motion, presence of swelling, erythema, and warmth should also be noted in any joint. Check also for contusion, abrasions, and edema, which are common signs of trauma, and evaluate the range of motion for each. For the back and spine, we should inspect for any abnormal deviation, such as presence of scoliosis, kyphosis, presence of muscle wasting. For we should also note for presence of mass and tufts of hair, as in case of spina bifida. So for examination of the genital and rectal examination, um, in the case of an adolescent, it may be more appropriate not to have the parent in the room with you. This may allow the patient to feel that they can be more candid. To avoid possible legal issues, a male doctor may want a female staff member to be examined in the examination room and maintain privacy. So in the examination of the genitalia, it involves noting the lesions, abnormal discharges. For males, note for presence of descended testes and Gardner staging for adolescent. For rectal examination, anus should be inspected for position, um, any fissures, trauma, presence of rectal prolapse. The rectal exam is mandatory for any child complaining of abdominal pain, having constipation, hematochezia, or melena. So for adolescent male and female, Tanner stage of genitalia is also important to note. Tanner staging is a measurement for sexual maturation. So not all parts of the neurologic examination is possible to be performed in a child. Much of the neurologic exam comes from observation of the child, and the rest depends on the creativity of the examiner.